developing a question for a board exam, you would want it to be something that's very straightforward, that you could have visual pictures or videos for, that would be very high yield. And so M mode kind of fits that mold perfectly. So it's actually pretty high yield on the boards. It's not overly used, but it's probably more used on the boards than you're going to see it in your clinical practice. But I'll tell you, even today with one of our patients, we were using M mode to assess for both mitral and aortic valve opening and function, and proved to be very useful. So I think this is going to be a high yield lecture for you guys in your clinical practice at the bedside, but also for your board exams. So this is the main paper that everyone comments on regarding M mode. It's Feigenbaum's paper. It's from 2010. It has a lot of the high yield pictures that you're going to need to know for your board exam, and we're going to hit a lot of the main topics today. This is going to be we're going to do a quick 20 minutes on M mode. I'm going to give you a lot of high yield images that I'll send out to you guys, and you can have if you want to review them more slowly. And then we're going to go through some questions that again are all high yield, some stuff that you'll see on the boards. So what is M mode? M mode's actually pretty straightforward. You're basically taking a 2D picture of the heart, and you're trying to turn it into a visual video. So basically what you're doing is you would be taking a specific scan line down the heart by this atypical red line that I just drew, and you are going to be scanning over this one line the entire time, and on the x-axis is time. So everything along that line will be constantly imaged, and all of the movements that it does, that structure does, will be dictated and shown on the image on your right-hand side of the screen, this image here, okay? So this image in particular, if you take a look through the line that I'm drawing, is going right through your aortic valve, and we'll go through the aortic valve in particular here. And as the aortic valve is closed, we see our line marked by this red line that I'm drawing here, and as it opens, I got a Gmail, as it opens, we see that the valve itself opens, okay? So why do we care about using M mode? Well, M mode has high temporal resolution. So do you remember we spoke about axial resolution, right? And temporal resolution is a little bit different. Temporal resolution looks at the ability to determine between two separate things happening over a period of time. So if I'm incredibly fast and I run across the room in a millisecond, right, just like Hirsch does, I would, and I had very slow frame rates, I would only see a picture of when I started and when I finished. But if I had a camera that took a million pictures in between, I'd actually be able to make a movie out of those pictures and watching me move across along that line. And that's what we're doing in the setting of M mode. So structures that move very quickly are very amenable to using M mode, like specifically valves. So here we see three separate lines, and these are what the different valves will look like or chambers will look like, depending on where you put your M mode structure. So this first one here at the top is actually this line through the LV chamber. And as the LV gets smaller, the chamber gets smaller during systole, we see that area in that chamber also gets smaller. And when it widens in diastole, we see that area that opens up once again. Again, we'll go through this in a few minutes, but the most important structures you're going to want to focus on are your mitral valve and your aortic valve. So in our second image here, number 2, we're putting our M mode cursor through the mitral valve here, okay? And I'm going to draw this so you can see how it's formed. So in diastole, so if we take a look, this is our septum, this is our septum, this is our right ventricle, this is our right ventricle. Do you see how it all lines up by depth on your M mode pattern? Specifically looking at the mitral valve, which is this area here that I'm drawing in, when you are in diastole, the valve moves, the anterior leaflet in particular, moves upwards towards the septum, right? So we see the first part of diastole, we see our valve moving upwards here, and then as it reaches diastasis, it falls back down to normal, okay? Here, again, we see in early diastole, our Erling phase, we move our valve up towards the septum, During diastasis, it gets down back towards its normal position. And then we have its atrial kick, it kicks up once again. And that's what the normal mitral valve looks like. Does that all make sense to everybody? Good. So we go down lower in our third image, and we see this third line, which is through our aortic valve, okay? And we have the same structures here. We have our right ventricle, okay? We have the outer aspect of our aortic outflow tract. And in the middle here, this line, we see our aortic valve. So during diastole, the aortic valve is closed. So these two leaflets, there's coaptation to them, meaning they're stuck together, okay? So you only see this one line. However, in systole, what we start to see in this image is that those leaflets start to separate. And now we have opening through the valve through which blood flow could travel. And then at the end of systole, it comes back together in coaptation, all right? So that's our normal image of our aortic valve. Again, coaptation during diastole, valve starts to open and we see two separate leaflets open, okay? At the end of systole, they come back together and they form what looks like one structure again. And that's just the valve stuck together, okay? So you can look at a lot of separate things using M mode. You can look at your mitral valve like we just spoke about. You can look at your aortic valve and aortic outflow tract. We can look at the left ventricle as a whole. We can look at the right ventricle and specifically its systolic function, which we'll talk about in later lectures. And you can look at the pericardium. And we're going to go through examples of all of these. I'm going to move relatively quickly so we can get through our questions. And then you can go through and look at these later. All right. So this is just a normal image of our mitral valve M mode view. So we're looking at our anterior mitral valve leaflet, which is this leaflet here. Okay. What we do during diastole, again, is that leaflet starts to move in this direction. So then we're going to see the M mode structure of a structure moving upwards towards the septum here. Okay. So early in diastole, when the gradient is high between the atrium and the ventricle, we see our mitral valve moves upwards towards the septum, often hitting the septum. And then as that gradient starts to equilibrate between the two chambers, that leaflet starts to fall back, and this is a period called diastasis. Then when the atrium kicks and we get a little atrial contraction, we see that anterior mitral leaflet goes upwards again. Okay, and then at the end, it comes back together, and then this is our period during systole. Okay, that's our normal structure. We can also see part of the other leaflets here, but the actual way in which that moves is a little bit less visualized. Nonetheless, we see that during systole, there's coaptation between these two leaflets. So they will come together during normal systole. Okay, and here's just a little bit of a rendering of another picture that you can look at later. But on the left side, we also see our other structures like our pericardium here, right? Our right ventricular free wall, our right ventricle. This is the chamber of our LV, and these are the valve leaflets that we spoke about prior. All right, so these are going to be relatively difficult if you've never looked at M mode before, but we're going to work through them. So there's something that's different in this picture from normal. Can anybody in the room see something that's different here? Why don't we go through it systematically, right? We have our intraventricular septum, okay? And we have what looks like our period of systole right here, right? What part is this?
That's the mitral valve leaflet going up.
Good. That's early diastole, the E part of our diastolic phase. We come back down and we have our A wave, right? So as the atrial kicks. But we come back here, this looks different. Doesn't look different to me. What's different about it? Yeah, for some reason, it's hitting up against my intraventricular septum, right? We're looking through this line if you look at the top of the screen here. So something is moving up. This is called SAM, or systolic anterior motion of the mitral valve, right? And this is something that's very well seen on M mode. And so if you have someone who's incredibly tachycardic, the heart rate's 130, right? They have evidence of, right, cardiomyopathy here with a thickened septum. You're actually having outflow tract obstruction, and you can see the chamber of your left ventricle is completely occluded in that same location. So what matters is, number one, that SAM is present, okay? But what also is really important is how much time does that coaptate valve hit up against my septal wall, right? So which do you think is worse, 1 or 2? 2, right? So 2 is hitting up against my septum and obstructing my outflow tract for a much longer time than the first image. And so this patient, number 2, is probably sicker and could be, in persistent shock because of this. Now, the treatment's pretty straightforward. It's you increase afterload, right? So you're increasing the gradient. So this leaflet doesn't come up and obstruct your outflow tract. And you also slow down the patient's rate. So putting someone on phenylephrine may be helpful because that may actually cause some reflexive bradycardia, but adding esmolol onto this kind of patient may actually be really helpful as well. All right, so here's that same image, right? Normal diastole and evidence of SAM. If we look through here, you see this little yellow marker here. We can look at the next image. Do you see that this posterior leaflet there's no coaptation with the leaflet that moves up against. So you actually also see some prolapse of the mitral valve in that region. So you may actually have some mitral valve regurgitation during that same period. So normally you would want these two to be stuck together, but we see evidence of that posterior valve going backwards. All right. Here's another great example of mitral valve prolapse, where here we see our normal diastolic section, right? But as we come together and we want the leaflets to form one singular structure, we notice that this mitral valve leaflet is prolapsed posteriorly, and you may have some regurgitation there, okay? These are two very high yield findings, both in clinical practice, but also on your board exams. Let me just delete this. And here's just once again another example of mitral valve prolapse. And again, when we have prolapse, we're having opening of that mitral valve so that you're going to have regurgitation backwards. So if you put your color flow Doppler in that same region, you may see an area of regurgitation. Again, apparently when I made this lecture, I really love mitral valve prolapse. All right. So what do we see here? So people who are at home are a little bit off the hook. So there's something different in our diastolic phase, right?
Yeah.
We don't see our normal
two peaks.
Peak, right? We see one slow descending line here. And this is very typical for mitral stenosis. Okay, so I'll actually give you an example, and I wish it happened. Well, I don't wish it ever happened, but I wish it happened earlier in the day. I would have added to the lecture. We had a gentleman who had a large mitral valve vegetation, who developed acute pulmonary hypertension. Right? We put M mode across the mitral valve, and we see something that looks very similar to this. While he did not have strict mitral stenosis, the vegetation itself formed the same kind of pathophysiologic finding. And that patient developed acute pulmonary hypertension because of acute mitral stenosis because of that vegetation. It was a really interesting case. We can send it out later. So the things that you're going to find in mitral stenosis are this decreased E to F slope. So that's this region here. We see how thick and white those leaflets are compared to the other leaflets. You see this area, how white this is? That corresponds with the thickness and calcification of that valve itself. And then we see that the posterior leaflet, which is here, right, moves at a pretty lateral motion. So these are the three major findings that you'll see, although seeing this decreased E to F slope is what you'll probably see the most time in your clinical practice. All right. So I already gave the answer away to this, but there's something a little bit different. I want you to try to think independently on it, that we have a relatively normal diastolic phase, right? But again, when we try to look what's abnormal in this picture, we notice that this area, which is normally open, right, and black, is filled in with white. So there's something that's moving into this empty space that's normally there that the M mode is picking up. And one of the big tips for your boards are whenever you're looking at an image, always look at the top of the screen too. It may give you some more information. So we see that just posterior to this mitral valve, there's something there. And this is a very classic picture for an atrial myxoma. So every time that valve is opening and in diastole and moving upwards towards the septum, we see that the myxoma itself fills into that empty space. And that's where you see this white area here. Okay? So we'll talk about it in our masses and vegetation lecture, but atrial myxoma is the most common benign tumor of the heart. It's usually in the left atrium and does have risk of embolism. I've actually seen a patient who it was connected by a stalk, and that stalk actually broke off. So it looked like a bouncy ball that was floating within the ventricle. Really, she obviously didn't do well. All right. So let's go through this here. What is different? This is obviously an abnormal picture. There's something that's abnormal here. So let's go through it very classically. So let's start with our E wave. Does our E wave look different? No, E wave looks good. We move down towards diastasis, and our A wave. Does that look good? Okay. And then we come back down during systole. Oh wait, there's another wave, right? So that's abnormal. And then as we go down, so this is abnormal. And then we go out and we have coaptation of our leaflets, although there's something else that's abnormal here too. We talked a little bit about earlier. Sam, right? So we see an abnormal structure hitting up against intraventricular septum during our systolic phase. But the question is, what is this little dot here? So it's something called a B bump. Very classic in a patient who has elevated left ventricular end diastolic pressure, right? It's a late diastolic phenomenon. You can actually read multiple papers on the etiology of what drives this. So we don't have a ton of time to go through it, but it's very classic in the setting of increased LV EDP. All right, let's move quickly through our aortic valve. So this is our aortic valve finding where we have in diastole that aortic valve is closed and we have coaptation of our leaflets. Okay, then we have opening of our valve. We can see the movement of the outflow tract. The valve itself opens and we have blood flow that's going through the valve here. At the end of systole, those valve leaflets come back together with coaptation and we see one single structure once again. Does that make sense? All right. This is just a little bit easier rendering of everything that we're finding, right? So the anterior wall, the posterior wall, and this is where all the magic happens, looking at the aortic valve. Okay. So I like to think about these as kind of simplistically as possible, because if you don't think about these simplistically, the images can get really hazy and confusing, and you can kind of just give up on the question right away. But if you go through it in a systematic process, you're going to be able to figure out what's abnormal in that picture. And you should go through it systematically, like reading an EKG. You should read M mode, like you do that with every patient as you're doing your scans. So here, once again, I give you a little bit of I give you the answer right away, basically. But we have a normal structure on the left side, and we see that over here, our aortic valve opens, but that valve opening is very small, right? So the aperture through which blood's going to flow through the aorta is actually smaller, most consistent with aortic stenosis. We also can see here, see how thick these leaflets look compared to normal? So these leaflets are pretty normal here, but they're thick and there's shadowing and haziness there. And that's most consistent with aortic stenosis and a calcified valve as well. All right. So what are the things that we're going to find? We're going to find thickened leaflets like we see here. Okay. There will often be fluttering within the aortic valve as it's closing. We haven't seen any images of that. We may show some in the next few slides, but you're going to see decreased fluttering because as the valve is floating back into place, because that's really what it does, because it's so thickened, it doesn't have those fine movements. It just kind of falls back into place. And then decreased excursion, which we see by the marked 1 centimeter here. All right. So here we see, what valve are we looking at? We're looking at our aortic valve. Okay. And what do we see that's different here? So we go through our structure. We have our diastole here, and we start to open, right? Does this look normal to you, this whole section? So this is in the setting of hypertrophic cardiomyopathy as that valve starts to flutter and close earlier than it normally does. So there's earlier closing of your aortic valve leaflets. And we can see, again, another little tip that we look at during our board exams. We look at all of our images on the screen, and you can actually see your thickened septum right here, consistent with hypertrophic cardiomyopathy. And what might you see on your M mode structure? Talked about it a couple times, very high yield. We'll see systolic anterior motion of the mitral valve very often in this. And so you're going to see during systole, that valve push up against the septum where it's normally not there. All right. So this is another picture of aortic valve. And let's go through it again systematically. We have coaptation of our valves here, and we start to open once again. But then at the end, it almost looks like part of the mitral valve, doesn't it? It almost looks like you just are looking at the E phase of the diastolic, but you're actually, if you look at the top of your screen, we're looking through this area here in the mitral valve. But I don't see an E wave, do I? So what could be affecting the mitral valve to make it start to kind of be pushed down? You see it's kind of fluttering here. Something's pushing it backwards, and yet when
regurgitation.
Hirsch, you're on fire. You're like the new Unica of Echo Board Review.
I'm Unica 2.0.
You are Unica 2.0. All right. So as you have aortic regurgitation, you start to see it pushes that valve closed during that same phase, right? And then your E wave is barely existent here. Okay. And so if you were to look at your mitral valve in your short axis view, you can actually see that valve bowing inwards. Are you getting text messages from Unica?
No.
Okay.
Not yet. I'm texting her first.
Okay. All right. So now let's very quickly go through our left ventricle because this is pretty low yield, to be honest with you, on the boards, right? We have our right ventricle. We have our septum. Okay. We have the chamber of the LV, as you can see on the left-hand side of the screen, and we have our posterior wall here. All right. As the mitral valve, as we have systole, where the actual chamber closes on itself, right? We see a systolic phase. And here, when it's the most wide, we see a diastolic phase. Does that make sense? All right, good. So here's a couple examples of what you're looking at. So our end diastolic volume can be calculated looking through here, and our end systolic volume can be calculated looking through here. All right. So we'll talk about it, I believe next week we talk about LV systolic function. Dr. Patel is going to be taking us through that. But this is an example of something called fractional shortening. So fractional shortening is your left ventricular end diastolic diameter minus your left ventricular end systolic diameter. So this minus this divided by your left ventricular end diastolic diameter times 100. And that's going to give you your fractional shortening. Fractional shortening is not the same as ejection fraction, right? So a fractional shortening of 25 to 45% is going to be normal. So less than that is abnormal. Now, you can imagine that you need all of your walls to be functioning well for this to actually be reliable. So if you had an inferior wall myocardial infarction, this posterior wall is not going to move very much, and therefore fractional shortening is not going to be a good way to assess your systolic function. Okay, and so what you may see on your board exams are not actually to apply fractional shortening, but what the problems are with using it. The other thing is, if you are cut on an oblique angle here, you may underestimate what your chamber size actually is. And everybody loves E-point septal separation as a way to estimate for your left ventricular function. So if I hit a big dilated left ventricle. Okay, big and dilated with poor LV function. And I'm trying to have my valve move upwards. Okay, our mitral, this is looking through our mitral valve. The valve's going to move upwards towards the septum. If that chamber is so large, that valve is never going to reach upwards and close to the septum. So you're going to have a large separation called your E-point septal separation. The number to know is 7 millimeters. That greater than 7 millimeters shows me that I have a dilated left ventricular chamber. Okay, most consistent with someone who has, dilated cardiomyopathy. So you may see this on the boards. It's kind of an old school way of looking at chamber size and left ventricular function, but it is consistent with a big dilated LV. Okay, some problems with this are mitral stenosis. So if your mitral valve is really stenotic and can't move up, it's going to falsely elevate your E-point septal separation and kind of overdiagnose dilated cardiomyopathy. And if you have aortic regurgitation in which this valve is not able to move up, remember we talked about it before, it flutters this area down here, and then your A wave is very small, it's going to, again, overestimate the possibility that you have dilated cardiomyopathy. Does that make sense from a functional standpoint? Good. All right. And then in RV systolic function, we can use actually how the myocardium moves as a way to estimate someone's systolic function of their right ventricle in particular. So here we have on the left side of our screen, we have our RV and we have our RA. Our right ventricle moves very differently during systolic function than does our left ventricle, right? It's this big floppy chamber that wraps around the left ventricle, and it doesn't compress in a concentric manner. It mostly moves from the base to the apex. So this base is going to move upwards towards the apex and vice versa. So we can estimate how well our right ventricular function is based on how well that part of the myocardium moves. And so here we see that if this part of the myocardium moves upwards a lot, right, a large distance, then the systolic function is good, right? And the number to remember is 1.7 centimeters. So if you're moving greater than 1.7 centimeters, you're having good right ventricular systolic function. If you're moving less, then again, you're having less good systolic function. It is dependent on loading conditions, and patients who have a lower right ventricular systolic function have a higher risk of death. That makes sense, right? People who come into the ICU in the setting of pulmonary hypertension, whether acute or chronic, have a higher mortality than their counterparts without that disease process. We'll have a whole different lecture on RV function, and there's other ways to assess for it.
And you get that by putting the MO through which part of
so you get your apical an apical four-chamber view,
yeah.
And then you go to your lateral wall of your right ventricle, and you put your M mode through here to get right at the annulus of the tricuspid valve.
Okay.
And then you're seeing how far this is moving upwards or downwards. And then you can see it correlates here. So basically you take your cursor and you measure from the top to the bottom here. And this area here should be 1.7 centimeters or more.
Okay.
Okay?
Okay.
Good. So again, look at the top of our screen. Do you guys see any obvious pathology there? And then try to correlate it down with your M mode. So we are looking through our right ventricular free wall, right? And our LV chamber here. Okay, we see our M mode going all the way through. So if you look in clinical practice, we should be applying our ECG leads, right? Very often we don't, and so we have some limited information. But on your board exams, these will all have ECG leads. So we know that we're in systole during this phase, right? And we're in diastole during this phase here, okay? So if we go through our structures, we see our pericardium, right? We see something abnormal here. We see our right ventricular free wall, our right ventricular chamber, our intraventricular septum, and then this we're all familiar with as our mitral valve, right? And our LV. Structures all make sense to everybody?
Mm-hmm.
Okay. So something abnormal is happening here primarily because there's an arrow on the screen. Okay. And that's not there in real life. So during our diastolic phase, right, what do we see happening?
The RV is
RV.
collapsed, which
Yeah.
is RV
Right.
diastolic collapse.
Our right ventricular free wall is moving inwards,
Yeah.
right? And that's right ventricular diastolic collapse, consistent with tamponade.
Mm.
Okay, and this is one good way when you're trying to evaluate and everything's moving very quickly. Again, the temporal resolution is so good on this that you're able to see this in slow motion using your mitral valve. So very helpful. All right. So here we see, just like we were looking at our systolic anterior motion of the mitral valve, the duration at which we have collapse, a diastolic collapse of our right ventricular free wall correlates with severity of disease, right? So here in picture 1, we see just a little bit of collapse there, right? So that fluid in the pericardium, the pressure is so high during diastole, right? Or the pressure is relatively constant, right? Changes a little bit, but it's relatively constant. When the chamber itself has a very low pressure, like diastole, right? The pressure is lowest in the right ventricular chamber during diastole, right? Because it's not contracting. Then the pressure in the pericardial space is overcoming that and pushing downwards. And there's not enough pressure in the LV chamber to keep that wall open. And here we see this is very severe right ventricular diastolic free wall collapse. Okay. All right, so let's take a look here. Do you guys see anything? So this is hard because I don't have a respirometer here, but do you notice this? So this is our right ventricle, right?
There's valvular variation, I think, with the respiratory cycle.
Good. So that's great pickup. So there's something's abnormal between here and here. We see that, and it corresponds with our right ventricle, right? So something is changing in our right ventricle during something happening. And sometimes you'll see something called a respirometer on your machine where it'll tell you when you're inspiring and when you're exhaling. But what we're noticing here is that this is exhalation and this is inspiration in a spontaneously breathing patient. And so we see our chamber is very small as the patient's exhaling. It's very large during inspiration. And so there's changes during that phase. So what could this possibly be?
Pulsus paradox.
You're on fire today. So what we
Suck it, Unica.
what we see is this is a patient with constrictive pericarditis. Okay. Now we're going to go over a whole separate lecture of pericarditis. So I'm not gonna dwell on it too much. But there's a couple findings that you'll see. You'll see respiratory variation in your RV chamber size, but you're also going to see an early diastolic dip, and that's very common in constrictive pericarditis. But look at the whole picture. We look at the bottom here. Look at this pericardium. Look how thick and white that is, right? Very hyperechoic. So that is consistent just with every other thing that we see on echo, that those things that are really thick and almost calcified are going to be very hyperechoic and white. So that's another example of looking at the entire picture to give you hints. All right. So what I'm going to do is I'm going to bypass some of this, and we're going to go to some questions that we have. All right. So now let's focus on some questions that you can get out of the Asher and Klein book. So who wants to read? Anybody?
I can read.
Real loud so everybody can hear on the...
Calculation of the left ventricular mass on the basis of M-mode echocardiography assumes that the geometry of the LV is spherical, elliptoid, cylindrical, none of the above. I didn't say I could answer it.
No, that's fine. These are questions that we didn't go. We use questions to do stuff that we haven't gone over yet either. And I'll tell you, this is a question that's on your board, right? You're not often going to be calculating your left ventricular mass necessarily. There is an equation for it that you can look up, but this is a question that you often see based on shapes of chambers.
I think it's cylindrical.
Okay.
Ellipsoid.
So we got one for cylindrical, one for ellipsoid. Mike?
I was going to say cylindrical.
We got two for cylindrical. All right.
B.
There we go.
There's a lot of B's over here.
I love it. I love it. So the answer there is ellipsoid.
Guess you're not Unica.
No.
So which parameter of systolic function is independent of ventricular preload?
Which
If anybody wants to, on the line, wants to yell out, that's also good. We'll make it very interactive. So ejection fraction. Is ejection fraction dependent on preload?
Yes.
Is it? Ejection fraction.
Oh, it's the
So the
it's a
fact that I said that,
percentage.
no, right?
Oh.
All right.
Yeah, I would think it would because it's still dependent on your end diastolic volume. So it really wouldn't matter for that.
Okay. So how about peak dp/dt? Have I gone over that yet? No. So would I involve that in this question? No. All right. So the true answer here is end systolic volume, right? So it's independent of your ventricular preload. All right. According to American Society of Echocardiography guidelines, LV chamber dimensions on 2D echo should be measured how? Again, this will be on your boards and is important in clinical practice.
Leading edge to leading edge. Keep in mind that unlike everyone at home, we don't have it opened up to that page in the Echo textbook.
Right.
So
Yeah.
like we're actually answering truthfully, unlike them.
Yeah. So the true answer is its actual tissue to blood interface. So it really is none of the above. But most people would tell you when you're measuring things that you want to do leading edge to leading edge. So what you're saying is correct. But when it comes to LV chamber dimensions in particular, and this is why I include this one because it's counterintuitive to everything else you're reading or whatever one's actual reading right now when they're answering at home. It's none of the above. It's tissue to blood interface. Okay. Who wants to read this one?
When comparing two-dimensional with M-mode echocardiography, which of the following statements is true? A, the axial resolution of M-mode echocardiography is superior to that of 2D echo. B, the temporal resolution of M-mode echocardiography is superior to that of 2D echo. C, the axial resolution of M-mode echocardiography is inferior to that of 2D echo. D, the lateral resolution of M-mode is superior to that of 2D echo. I think it's B. Like we talked about this.
Good. So this is regurgitated from the lecture, right? Temporal resolution of M mode is superior to that of 2D dimensional echo. Your eye, right, is not as good as M mode is, right? And the machine itself, right, is basically what you're seeing in your eye because the frame rates are relatively high. So you can use M mode in very high moving, fast moving structures.
A and C seem mutually exclusive. That part was confusing me. So it seems like one of those would have to be
The
true.
axial resolution of M mode is superior to that of.
Is it so the same? Is it the same axial resolution?
So it's the actual. So what is axial resolution? It's the between the two. That's not going to change much in your M mode. What you're going to really get is because M mode's everything's going to kind of blur together on that line very often. So you can't delineate between two separate topics, two separate things on one part or the other.
So it's the same.
Yeah. Which of the following conditions is most likely to be associated with pseudo-dyskinesis on two-dimensional echo? So everyone at home is Googling pseudo-dyskinesis right now. Hirsch is smirking and texting on the side, like a good student.
I'm guessing E. I didn't Google it.
My guess is E.
Was that Yanika?
Actually, she heard Mike say it first.
Okay.
I'm pretty sure.
All right. So let's do some test taking practice, right? You're all obviously in medicine, so you're probably wonderful at tests. Pseudo-dyskinesis. So what do you think that is?
It's not. It looks like it's dyskinesia. but
So
it's not.
looks abnormal,
Yeah.
but it's not. So you went with left bundle
Yeah.
because that would make sense, right?
Yeah.
Okay. Will coronary artery disease potentially cause something that sounds like that?
No,
That would be
normal
dyskinesia.
dyskinesia.
Good. Constrictive pericarditis?
No.
Not really, right? Liver disease?
What the fuck?
Maybe. How?
Sure.
Yeah. I mean, what the hell?
Maybe?
I don't know, maybe.
And an atrial septal defect. No. So we got to pick between the two. What I'll tell you is that the answer is actually liver disease, and we're going to go over what then we're going to go over what pseudodyskinesis is. It's just a power move to make me feel like I'm smart, right? That's what lecturing is. All right. So let's see if this actually works. Okay. So this posterior wall. Sure. Well, we'll just go on to the next question. All right. So this is an M-mode echo taken from a study of a 48-year-old male with dyspnea. Blood pressure is 120/90. What may be said about his hemodynamic state? There's severe aortic regurgitation. The LV-EDP is high. The stroke volume is normal, or the stroke volume is low. What do we think? So we're looking for our M-mode, right? We see coaptation of our valves. They begin to open, and then we get back down to systole. What do we notice in here? So our LV chamber, our septum, right? Is our intraventricular septum normal? Right? Normal. Right? Is our LV chamber normal? No? What's wrong with our LV chamber? It's a little big, right? And we see this, while there's not great measurement here, this is maybe 11, and this is maybe, what, 14-ish? So we have almost 3 centimeters here, right? So it's pretty big, right? Our E-septal separation is what, 7 millimeters usually? So we have a big separation between our E-wave of the opening of our mitral valve during diastole and where it hits the septum. Okay, so what would that tell you? Potentially.
Dilated cardiomyopathy.
Dilated cardiomyopathy, right? Except in the setting of
Mitral stenosis or aortic regurgitation.
good, perfect. So no aortic, no mitral stenosis, and no aortic regurg, right? And so we think that there's dilated cardiomyopathy, right? So let's go through these. There's subaortic regurg. Is there any evidence of that here? Right? We don't really have fluttering of this E wave. Everything looks normal, and these waveforms not present. Okay. Our LV-EDP is high. You see anything to prove to you that your LV-EDP is high? What finding will we look at before?
That would be like sort of more gradual descent, right?
Well, that would be your mitral stenosis,
yeah.
right? But there was a finding that we talked about that looked for increased LV-EDP.
Brian B bump or AC shoulder.
Yeah, there you go. B bump, right? Do you see a B bump? No, I don't really see one, right? So that can help take that away. Now you have to decide, is the stroke volume normal or is the stroke volume low? And this is probably not the greatest of questions. And in all honesty, I chose it because I like the other things, the aortic regurg and the B bump, to kind of hammer those points home. But if you were to do your fractional shortening here, it would be pretty small, right? The difference here is 6 centimeters versus the smallest area is about 5.5 centimeters. So that'd make your fractional shortening very small. So you probably have a low stroke volume, right? So again, this is not the greatest question for the answer, but it is a great question looking at the other pathologies that we wanted to review. Okay. So we talked a little bit about our aortic regurgitation, right? We go through our mitral valve here, and we see that there's fluttering. You can see a fluttering here, right? And we don't really see much of an A wave, right? And that's very consistent with aortic regurgitation as it pushes back against our valve, right? So based on this pulse wave spectral Doppler profile taken in the right ventricular outflow tract just prior to the pulmonary valve, which of the following findings on M mode recording of the pulmonic valve would be expected? I don't know why this is so goofy. So the truth is, A is not the answer, so don't worry about that. Prominent A wave, mid-systolic closure, M mode recordings of the pulmonic valve are not technically possible. So if we're looking at this, what are we seeing here? There should have been a picture in this one. I don't know why it didn't show up. But we're looking across the pulmonic valve, right? We didn't go over this, and so this is a good area to go over it. So normally, if we're taking a look at our, if we're taking a look across our pulmonary outflow tract, and we put our M mode there, we're going to see the pulmonic valve move in certain directions, right? So normally, when there is atrial contraction, right, your pulmonic valve moves in an A-wave fashion this way, okay? And we lose that here. We don't see that, okay? For some reason, during mid-systole across your pulmonic valve, you see that that valve starts to move backwards. And that doesn't make a ton of sense, right? Why do you think that would be? And this is hard. I want you to try to think through this because this is a really important finding in the setting of pulmonary hypertension, but it's very difficult to determine why it happens. So there's a couple different possibilities. So if a patient has pulmonary hypertension chronically, their pulmonary artery is going to be big and dilated, right? And those valves don't go all the way outward to the end of the artery. They kind of get stuck in the middle of it, and they start to float back, okay, into the midline, and that's where this area is coming from. And that's what most people think is probably what's causing it. And there's turbulent flow in this region, causing the valve itself to flutter in the middle of systole coming out of the right ventricle, right? So a little bit counterintuitive, but this is called a flying W sign, right? And it's consistent with chronic pulmonary hypertension, not acute pulmonary hypertension. So we're going to talk about RV function later, but this finding, okay, the flying W, is tested on board exams repeatedly, okay? You don't use it a ton in your practice, but you can imagine it's a very easy image to put up for M mode, so you're going to see it very often. So here we see the normal physiology that happens. And in pulmonary hypertension, during the mid-systolic action of it, we see the posterior movement of our pulmonic valve. And that's consistent with a chronic pulmonary hypertension stage. So again, you have your A wave, but we lose our A wave in pulmonary hypertension. And as the valve slowly starts to close, as we move forward through systole here, we actually see that it closes at a quick, rapid pace, and then finally opens once again. And that's called your flying W, just to kind of drive it home. Here's a more real-time picture of an M mode, kind of what it more often looks like, is we see no A wave here, right? So the atrial contraction isn't really large enough to affect the right ventricular chamber so much because the RV chamber is probably so big and dilated and hypertrophic already, right? And so there's no effect of that atrial kick on the leaflet itself. And then in the mid aspect of systole, we start to see bowing backwards of the pulmonic valve. Yeah, so here are some findings we talked about. So your diminished A dip, and then your systolic notching that we talked about. Okay, so this will be on your boards. Again, you may not use it every day in your practice, but it'll help determine whether someone has chronic pulmonary hypertension versus acute pulmonary hypertension, and it's probably due. And again, there's no definitive studies due to the dilation of the pulmonary artery that causes this to all happen.
Which view are you using to put M mode through the pulmonic valve? Are you using a parasternal short?
So you take a parasternal short axis view, right, and then you fan it upward. So a parasternal short axis view looks like this, right? With our papillary muscles, we fan upwards, and we start to see our valve leaflets, right? Then we keep going, and we see our Mercedes-Benz sign here, right? On the right side of the screen. On the right side of the screen, we'll start to see our tricuspid valve. And out here, we start to see our right ventricular outflow tract. This area here is our main pulmonary artery. And this is our pulmonic valve. And so basically, we put our M mode across this valve here. Gotcha. Right?
So you have to be tilted pretty far up.
Yeah, so you start again with your parasternal short axis view for the first years watching with your the button located facing your left shoulder, so your proximal shoulder, to get your short axis view. You are going to fan the probe upwards towards the opposite shoulder. So basically going to be dropping your hands closer down towards the patient's body to kind of fan and open up everything that's more anterior and superior. And sometimes what you can do is once you've gotten to this aortic valve phase, you kind of rotate your hand a little bit to the right. So you take the palm of your hand and you move it down to the left of you, and it's going to turn the probe to find all of these structures here, because normally your aortic valve will be right in the middle. And we'll do that kind of in clinical practice. We'll go through that when I work with you guys. We'll go through each probe position, because this is a really important finding. It's a really important view to be able to obtain, and certainly it's much easier to obtain in your transesophageal view, right? This is your right ventricular outflow tract view, and you rotate a little bit more and you see your main point. A 55-year-old woman is admitted to the hospital with syncope based on M mode. Which is your diagnosis? So what do you see here? So we're looking through our mitral valve, right, at the top of the screen.
Yeah.
Let's go through it very systematically. What do we see? So what phase is here?
That is diastole.
Well, let's look down here, right? So
That's
systole, right? Good. So this is systole. This is diastole, right? Our E and our A. And then we go back to systole, and what do we see? What is this? Systolic anterior motion of the mitral valve, right? This is, I promise you in your clinical practice, this is how you will use M mode. You will use it primarily looking at this, looking for dynamic outflow obstruction, and it will be tested on your boards with at least one question, maybe a couple. A 26-year-old woman with chest pain, we're almost done. So a woman with chest pain and shortness of breath presents to the hospital. Heart murmur is auscultated. Medical team caring for the patient requests an echo to evaluate her heart murmur. Based on these findings in the M mode, which of the following descriptions would best characterize her heart murmur? So what are we seeing on this screen over here? What do you think you see? So again, we're looking through a mitral valve, right? This looks like a mitral valve tracing. Does anybody want to come up with the pen and take me through systole or diastole? Take that as a no. All right. Yanika, if you were here, you would do it, right? You'd probably make a milkshake.
Yes.
Good, thank you. All right.
There's some prolapse there.
Good. So we see mitral valve prolapse, right? So let's go back to our medical school days. When do we hear mitral valve prolapse murmur? Is it a whole systolic murmur? No. Early diastolic murmur with a soft one? S1? No. Good. Diastolic rumble with a prominent S1? No reason for that, right? Would it be affected by Valsalva?
Yes.
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 Yeah, it would. I think. Yeah, it would. Yeah. I don't know. Ask one of the guys taking medicine board this year.
So what finding do we see that is altered with Valsalva? What classic medical problem? We just talked right?
Yeah.
So this is trying to get you to pick systolic anterior motion of the mitral valve, right? And our mid-late systolic murmur is actually, this is mitral valve prolapse here, okay? I don't remember a lot of questions on the boards regarding murmurs, but what I really like is that you can, the answers are kind of confusing and intimidating, but when you go back to the actual picture itself, you have the diagnosis, right? And then you can reason through the rest of the stuff. So you have the baseline knowledge that you need in order to get the answer, right? Well, some of us do, some of us don't.
That's a bad question.
Yeah. All right.
The whole point of
I'll email Dr. Asher. All right. So this is our mitral valve prolapse, right? When they're supposed to have coaptation, we start to see that leaflet, this leaflet, and this leaflet separate. Good. And this is an example of why you're going to have that murmur. It's because it's going to be secondary to regurgitation. And again, just for the record, for everyone that's on the on this WebEx meeting, Hirsch is potentially the worst misbehavior in lectures I've ever met. He just giggles every time he looks at his phone. We're gonna have to work on that for him. Maybe get him like an iPhone or like an Apple Watch or something. All right. Who wants to read this one so I don't have to read it?
7-year-old woman collapsed after a heated argument with her son. Presentation in the emergency room. She is complaining of chest pressure, severely hypotensive, and has a loud hollow systolic murmur. Taken to the cath suite where she is found to have no obstructive coronary artery disease. PEE is performed from which a following M mode is obtained. What is the most likely explanation for severe hypotension and systolic murmur? Flail aortic valve due to bacterial endocarditis, dynamic LV outflow tract obstruction, acute severe MR from papillary muscle rupture, or a previously unrecognized subaortic membrane.
Think, is that a B bump?
Yeah, it looks like a mitral valve trace.
So this is really interesting.
Yeah.
It does look like a mitral valve tracing, but what if I were to tell you that this is not a mitral valve tracing? Well, look at this. Does this septum look the same size as it normally should? It's pretty thin, right?
Yeah.
Now, in your boards, you're going to have another picture of where the M mode's going through on all fairness. But if I were to tell you this is an aortic valve. So let's think about it. So she's 70, she's hypotensive, and she has a loud holosystolic murmur. Okay? So number one, that's going to take you through a differential diagnosis. Okay? She's taken to the cath suite. She has no obstructive disease. Okay? And the M mode is obtained here. Okay? So what could potentially cause holosystolic murmur, even if you don't know what this M mode is, and after this question you will. What causes a holosystolic murmur and hypotension? Mitral regurgitation or
Aortic. Well, it won't be
Yep.
holosystolic if it was aortic stenosis.
Right.
It's really crescendo.
okay. But you're saying a systolic mitral outflow obstruction, right?
Mhm.
Something blocking the flow going through the aortic valve, right? So what are we seeing here? We see our valve opens, right? And then midway through, what's happening? It's starting to shut down, right? So something is causing this to shut, right? Would a flail aortic valve due to bacterial endocarditis cause this? No, but it would cause regurgitation. And that's what they're trying to get you to pick is, could this be aortic regurgitation? And it's not. Right? So here, dynamic LV outflow obstruction.
Sounds like it.
Right? There's an outflow obstruction, and it looks pretty dynamic that it changes throughout the course of the aortic valve opening. So maybe this. Acute severe mitral regurgitation with papillary muscle rupture.
Doesn't really fit the clinical picture.
Yeah, why would that show up in your aortic valve like this necessarily? Right?
It'd be hard with that clean cath, right?
Okay, good. And then a previously unrecognized subaortic membrane. So subaortic membrane is basically just prior to the mitral valve, you actually have a membrane formation that causes obstruction, right? So what's the difference between these two, right? One is fixed and one is not, right? Your fixed obstruction isn't going to have this particular picture. So this is actually consistent with a dynamic LV outflow obstruction. All right.
Can you get the 70-year-old without with a sub
In the bathroom.
I would say no most often, but that doesn't, a lot of times that if patients are hypotensive, they can have a relative outflow obstruction. So you'll see patients when they're really hypotensive and they come in and you see that they have this evidence of this, you give them some fluids and that goes away. So I don't think this is congenital hypertrophic cardiomyopathy, but rather related to something else. Okay. Again, so this is early closure, right? And we see a dynamic process across the aortic valve. All right. We only have, I believe, 2 more questions. So 72-year-old with breast cancer and shortness of breath presents to the emergency department. M-mode images are obtained from parasternal long axis and subcostal views. Which of the following statements are true? So right atrial and right ventricular collapse consistent with tamponade. RV collapse, RA collapse, where there's no RA or RV collapse, and therefore there is no tamponade.
So for starters, you can only see the RV on the images. You can't see the RA. And I don't think I see the RV hitting the interventricular septum.
Do you think it needs to hit the interventricular septum? Or
No,
you think
I guess not. You don't need necessarily to have complete collapse. There definitely looks like there's variation, I guess. Yeah.
Okay, so let's go through. So this is good. This is good for everybody in the group. This is a good way to think about when you're taking your tests for the boards, right? And get into the pattern of using your ECG markers, right? Your ECG leads are so important in determining where you are in the cardiac cycle. And then hopefully this will encourage you to use the ECG leads on our daily practice. So this here, right, for the most part, is systole, right? Which would make this part here diastole. Go through your anatomy that we see up here. So here we have a fusion, right? Followed by our right ventricular free wall, right? Our RV chamber, our septum, our LV chamber, or really our aortic outflow tract, right? And what is happening to that free wall? Is that going in during diastole or is it staying?
It's going.
It's going in, right? So you're right. So there's RV chamber collapse, right? Now, classically, you want your right atrium So right atrial collapse should be greater than 1/3, right, of your time in that cycle. So when would the right atrium collapse?
Systolic.
It would collapse in systole, right? And why is that?
The lowest.
Yep. So the chambers collapse when the pressure is the lowest. So the chamber in the right ventricle is the lowest during diastole. It's the lowest in the right atrium during systole. So in tamponade, right atrial collapse during systole, right ventricular collapse during diastole. We don't even see our right atrium here, so you can't make that diagnosis, right? But we do see diastolic collapse in this section, consistent with tamponade. Good. And then this is a teaching point I just wanted to bring up to you because we didn't talk about it today. And we will talk about it in our pericardium lecture, but you want your right atrium to be collapsed greater than 1/3 of that cycle. All right. Last question. 42-year-old male with a history of palpitations and presyncope has the following 2D M-mode echocardiogram. On physical exam, he's his persistent widely split second heart sound. Which of the following statements are correct? Anybody want to read these out loud, real loud?
Findings are consistent with left bundle branch block. Findings are consistent with right bundle branch block. Findings are normal. Findings are consistent with pre-excitation. Sweet.
So we're looking through the chamber, right? So we have RV, we have intraventricular septum here, we have intraventricular septum here. We see our chamber, right? And our chamber. And we look at our posterior, and this is our posterior wall. Okay? So just taking us through everything. Let me see if I have a bigger picture. All right. So let's think about the cardiac cycle. Do all the walls move in at the same time during systole, or do they move in a little bit delayed? A little bit delayed. So which wall moves in first? And you're talking small microseconds, right? But which moves in first? Think about your conduction system. Where does the conduction system hit first?
I say the AV node.
AV node.
Yeah. And conducts down the right and left bundle. I guess right bundle first.
But it goes through your AV node.
Yeah.
Right. And where is your bundle of His? Or where's your His and Purkinje system? Start in your septum, right? So would it not make sense that your septum usually moves in a little bit before your posterior inferior wall, right? That makes sense?
Yeah.
Okay, good. So when we're looking at our systole here, right, do we notice that this posterior wall starts to move in a little bit before my septum, right? That's a little weird. That's abnormal. Now, this is a hard question, right? It's a good question to end on, right? So at least you get your anatomy, and then you're going through what's abnormal, okay? So which of these things would cause you to have your inferior wall go first, okay? And remember, presyncope and palpitations, okay?
So pre-excitation.
Good, awesome. So in the setting of WPW, based on where your location is, customarily, you're going to have pre-excitation of that inferior posterior wall, and that's going to move in first, right? So again, not going to be used a ton in your practice necessarily. I don't think you're going to be surprised if you're going to diagnose an accessory pathway on echo and not on your EKG, but at least it takes you through how everything moves during M mode, right? So normally your septum moves in a little bit before your posterior, inferior, or lateral walls. Okay, just keep that in mind as you're doing everything. And again, if someone were to be paced, right, the chamber that is paced and the walls that share are going to move in before the rest of the walls, right? So just think about that in the long term. All right. That's all we have for M mode. Do you guys have any questions?